Esteemed faculty and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on behalf of the entire team at Emcure Pharmaceuticals. We at Emcure are proud to present Empower Talk, our highly anticipated scientific program dedicated to exploring the multifaceted landscape of managing diabetes. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected with diabetes. Our distinguished moderator and expert speaker are poised to share their knowledge, insights, and practical wisdom to empower us in the fight against this health challenge. We are thankful to our esteemed moderator, Dr. Panir Selvam sir, and expert speaker, Dr. Vamsi Mohan sir, who have generously decided to share their time and wisdom with us. MCure is privileged to have a role in facilitating this bond. Let me have the privilege of introducing our esteemed faculty for this program today. We have Dr. A. Selvam sir as esteemed moderator today. Sir is Managing Trustee of Aruna Diabetes Research Foundation, Chennai, President Chulai Medu Civic Exnora, Chennai Diabetes Exnora, Chairman Lion KRS Insulin Bank for Juvenile Diabetics, Co-Chairman for Diabetes Association of India Southern Chapter, Chennai. Sir is co-opted member for Research Society for the Study of Diabetes in India. Sir is ex-project coordinator of World Diabetes Foundation and Gestational Diabetes Mellitus Project. Sir is national and regional faculty in diabetes space. Sir received Best Doctor Award, Government Roypeta Hospital in 1997, Dr. Anand Sinam Award for Insulin Bank in 2012. Sir is one among the top 25 diabetologists in the country in creating awareness on diabetes. Sir has attended many national and international conferences, and Sir has published few original articles on diabetes in national and international journals. Thank you, sir, for joining today's program. Let me have honor to introduce our expert speaker for today, Dr. Vamsi Mohan sir. Sir is senior consultant at SP Hospital and Orthomed Hospital, Chennai. Sir received Lifetime Achievement Award, Shri Vishnu Pratigra Tantigra Pitam, Chennai. Sir is Endocrine Society of USA trainer for 2 years. Sir has ADS speaker certification. Sir is speaker orientation in diabetes and metabolism summit Trivandrum. Sir is regional faculty member of PHFI. Sir is faculty for diabetes update for PG students. API Chennai chapter PG training program. Sir has participated at various national and international conferences. Sir is member of various scientific bodies, including API, RSSDI, and DIPSI. Sir is investigator of age study, obstacle hypoglycemia study. Sir actively engages in public health education on topics including diabetes prevention and dengue awareness. Thank you, sir, for joining today's program. Let me brief you all on the agenda for today. We'll start with the opening remarks and context setting by Dr. Panir Selvam sir. This will be followed by the session by Dr. Vamsi Mohan sir on role of sitagliptin and diabetes-based combination, dual and triple combinations in practice. This will be followed by quick comments on the session and question and answer session, which will be driven by our esteemed moderator, Dr. Panir Selvam sir. And finally, we'll have concluding remarks by moderator and vote of thanks. I would also like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Without further ado, let's embark on this educational voyage together as we endeavor to our understanding of the role of sitagliptin and diabetes and dapagliflozin based combinations for diabetes. I request our moderator, Dr. A. Panir Selvam sir, to share his opening remarks on today's topic. Over to you, sir.
Thank you, Dr. Rakesh and Emcure and my colleague, Dr. Vamsi, and all the participants all over nation. So it's a very good event. Emcure during COVID conducted a lot of online CMEs. I feel very proud and happy to rejoin again in Emcure for all over nation CME. So of course, today's topic is SITA, DAPA, plus or minus metformin. And some of us are senior people, some of them are youngsters, less than 40 years. So Vamsi and myself know, up to the year of 2000, we had insulin to start with from 1922 to till today. Then your metformin and sulfonylurea during 50s. These three classes of drug only we used up to the year of 2000. So if you appropriately titrate either sulfonylurea or insulin with metformin, definitely 20 to 30% face low sugar symptoms. For fear of low sugar symptom, many doctors may not treat properly first. Even if they try to treat properly, and many of them will face hypoglycemia. And for fear of hypoglycemia, many patients also will not go treatment properly. Once they had hypoglycemic attack, they throw away all the anti-diabetic drugs. This we have seen ourselves, and our teachers also saw just 20-25 years before. After the arrival of TZD, AGI, various gliptins, gliflozins, recently Glimin, GLP-1 receptor analog, these are all 6 new classes of drug. They are all non-sulfonylurea molecules, non-insulin molecules, which are safely controlling diabetes, preserving the beta cell function. Smooth control is there, no glycemic variability, no hypoglycemic episodes. This we are experiencing in many of our patients. And we de-prescribe sulfonylurea, we de-prescribe insulin for many of the patients after adding either sitagliptin or dapagliflozin with the existing sulfonylurea metformin combination, etc. So by this after the arrival of sitagliptin for the past 15 years, smooth control is very much possible, and attainment of A1C less than 7, earlier hardly 10 or 20% of the people. Those people also will face hypoglycemia. Now we could able to improve 30 to 40% under control without hypoglycemia. So in this area, so to talk more about sitagliptin, dapagliflozin, what are all the indications? Of course, these two molecules are well-studied molecules. The knowledge is globally shared frequently for those two molecules. And Dr. Vamsi also, such a senior person, has experience in this field for more than 30 years. Now over to Vamsi to talk on the subject.
Thank you, Dr. Paneer, and thanks, Emcure, for getting us all together. And also, good evening to all delegates who have joined in. So, this is how the
You can see.
talk will be. Yes. So today, let us see about the diabetes prevalence and what was the conventional therapy earlier and how we have changed the therapy in the last 10 to 15 years and how this has impacted how we approach patients of diabetes. As all of us know, there's an increasing trend towards higher number of people with diabetes. All around the world, it's extremely high. If you look at the South Asia, where we are, 90 million diabetic patients right now, Western Pacific, 206 million. That includes all the islands in the Pacific where the prevalence of diabetes is very high. So coming to Indian prevalence, we know it's roughly around 11 to 14%, depending on the state-wise data we have. And also probably an equal number of people who are pre-diabetic who can become diabetic unless detected and cautioned and counseled to reduce their diabetes load. If you look at this study, this idea of diabetes addition, 2000 to 2045, the number of people with diabetes has been growing up. Look at the curve here. From 2000 to, its projected increase to 245, about nearly 125 million by 2045. I think it should be more towards maybe 130 to 135 million because we normally underestimate these statistics. So anyway, it's a huge number. And all of these diabetes, if you go by the current trend of poor diabetes control, less than 1/3 of the patients are under the A1C of less than 7, around 7. You can imagine the number of complications that can arise in the future. And this is a challenge for all of us to get these people into control at the earliest possible time. And do we have the drugs now which can do that without causing pain? Earlier, say 15, 20 years back, like Dr. Paneer mentioned, we used to use insulin, sulfonylureas, bigonides. And then came the PPRs and the AGI inhibitors. All of them were good. They reduced the A1C, no doubt, but it came at a cost. Hypoglycemic episodes, increase in weight. And because of the hypoglycemia, the therapeutic efficacy because of improper titrate this. Because once you cut down the dose, the sugar seems to jump episodes or more. Therefore, the potency, altered side effects due to drug metabolism, the lack of target specificity, these drugs only control the glycemic targets. So there was no way we could target specifically the various pathophysiologies that cause hyperglycemia. We had no problems at that time, in the sense we could not use drugs. Now, with the passage of time and roughly last 2 decades, we had newer drugs coming to the market, like the incretin-based therapies, GLP-1 receptor agonists, DPP-4 inhibitors, and SGLT inhibitors. And these have revolutionized the way we treat diabetes. And also from the various studies, we have come to understand that beyond glycemic control, they also have an effect in reducing the lipids, have a pro-effective on the blood pressure, reduce inflammatory markers, and reduce oxidative stress. They also reduce endothelial dysfunction and probably reduce the ongoing atherosclerotic changes that occur in the blood vessels because reduce inflammatory factors, and also have a modest weight reduction. Both these drugs, this SGLT benefits among patients with type 2 diabetes, that we know that they are basically diabetic drugs. But also we have come to know they also have a major effect on the cardiovascular events, reduce CVD, reduce hospitalization heart failure, and slow progression of chronic kidney disease. Both CVD and CKD are in people who are uncontrolled, and up to 40% of people with diabetes of 10 years will have CKD at some point of time. And CKD and CVD go together. So it's very important that we reduce the glycemic control and use drugs to prevent onset of CVD or reduce the incidence and progression of CKD. Because if you look at this 2015 guidelines, so predominantly, apart from monotherapy and then dual therapy, sulfonylurea, thiazidine inhibitors, and GLP-1 came way behind. The predominant drugs used were the sulfonylurea and thiazidines. So this was in 2015. So come to a decade later in 2025, and let us see where these drugs are. So ADA has said that, yes, apart from lifestyle behaviors, please look for the presence of cardiovascular kidney risk in these patients, because we know all diabetic patients do have a progressive vascular disease. So if there is an ASCVD or indicates high CVK or heart failure or CKD, the drugs used are either GLP-1 receptor agonists or SGLT inhibitors with proven CVD benefits. Apart from this, if you look at it, this weight management has come into the fore. You know, obesity itself is a disease. It's a marker for increased atherosclerosis. It's a pro-inflammatory state. Therefore, we need to use drugs which not only control glycemia, but also help to reduce weight last 10 years. Now, recent trends in commonly used anti-diabetic medications. One is, of course, the pre-diabetes lifestyle takes a predominant role in pre-diabetes, prevent conversion to diabetes. We're going to use drugs, of course, metformin, all these drugs can be used to reduce the incidence of diabetes, preventing pre-diabetes from converting to regular diabetic patients. The traditional hypoglycemic drugs, now what we use, SGLT inhibitors, GLP-1 receptor agonists, DPP-4 inhibitors, and the initial combination therapy. No more traditional stepwise therapy of using monotherapy, stepping up the dosage. So we start straight with initial combination drugs like metformin DPP-4 inhibitors or metformin SGLT inhibitors. So these are the drugs now. The trend of treating diabetes has changed in a different location altogether. So we not only need to control glycemia, but also look at the cardiometabolic risk these patients have, adiposity, metabolic and vascular risk, tolerability, hypoglycemia and weight gain, and simplicity of sustainable compliance. One of the major reasons why we have such a low control for glycemia is compliance. Many patients do not comply with your suggestions or guidance, and they may not come back for dose adjustments or what we call titration of the dose to get them to control. Since early diabetes is asymptomatic, most of them think they are in good control. So the sustainability becomes important. Compliance of treatment is very important. So if the treatment is simple, we'll also achieve what is called sustainable compliance. Now, beyond glycemic control, we also need to address the complications. Now, diabetes is due to multiple pathophysiological changes. And unless we address all the background pathophysiological changes, we may not be able to reduce the complications that arise in uncontrolled diabetic patients. So we need to reduce risk of CV death. We need to have oral treatments. The oral treatments always, it's better compliance compared to insulin therapies or injectable therapies. Yeah. And also prevent weight gain or reduce weight. And of course, the major thing is reduce the risk of hypoglycemia, minimize the intensity of hypoglycemia in these patients. And also, these treatments must provide not only the glycemic benefits, but extra glycemic benefits, as we saw in the earlier slide. So let us look at the role of sitagliptin in management. Now, compared to metformin, D4 inhibitors seem to have a low risk of hypoglycemia. All these studies from 2010 to 20, all these studies showed that the risk of hypoglycemia is 56% lower with D4 monotherapy compared to even metformin. And sitagliptin is, of course, approved drug. There's intermediate efficacy, 0.5 to 0.8 reduction in A1C. There's improvement in beta cell function. There's a good circadian glycemic control, meaning it has a long duration of action. And there's a huge experience because now it is more than nearly 20 years since its launch. It's weight neutral, reduce hypoglycemia risk, and it's affordable drug to continue in the long run. Why is sitagliptin the favored D4 inhibitor compared to other drugs in the same class? One is selectivity. DP4 are part of the immune system, and we need to have that selectively inhibit only DPP4 and not DPP8 or 9 or FAP, which is a fibroblast activating protein. So here, if you look at the sitagliptin and linagliptin to be very selective in the DP4 inhibition, and its enzyme bind active sites beyond an S1, S2, both sitagliptin, 90% inhibition of DP4 with once daily dose. There's no dosage requirement adjustment with the drug-drug interactions is very low. Can be used in hepatic impairment, early and mild hepatic impairment. And it can be used in renal impairment once we know to readjust the dose of this. And the CV outcome study showed it is pretty neutral as far as the CV events are. It's a time-tested drug. It's convenient once daily oral regime, long potential drug-drug, low potential drug-drug interactions, good efficacy and safety profiles. It is CV neutral from the TCOS trial study, is weight neutral, good glycemic durability, and minimal glycemic variability, which is also a major factor in how we control diabetes. Glycemic variability should be minimal. Now, let us have the clinical evidence for sitagliptin. This is a Japanese monotherapy study compared to placebo. So this is the plasma glucose milligrams, and this is the change that can occur in the plasma glucose levels. And this is the placebo study. This is a sitagliptin study. So at week 12, from baseline, you can see the difference with placebo 11.7 decreased milligrams per deciliter, whereas nearly 70 milligrams per deciliter reduction in the plasma glucose levels. And this is the plasma insulin levels, which you can see again from the compared to placebo, the 0.05 between age group difference, as well as the insulinogenic index, which is much better compared to placebo with sitagliptin. Lowers A1C with once daily dosing. This is an 18-week study. So compared to placebo, this is the A1C with reduction with sitagliptin. And this is the 18-week study, the 24-week study, again showing the remarkable change in the A1C between the placebo and the sitagliptin. And this is a Japanese study which also confirms the A1C reduction is very good with usually up to 1.05% achieved on the base of 8.4% of A1C. Now, sitagliptin also improved markers of beta cell function. So how do we measure beta cell function? Well, the pro-insulin ratio. This is the treatment with placebo with sitagliptin. So at the end of the trial, as you can see here, the pro-insulin ratio came down significantly with sitagliptin compared to placebo. And look at the HOMA beta index. This is again at the end of the trial study. The HOMA beta index improved significantly with sitagliptin compared to placebo, again showing that markers for beta cell function improved when we use sitagliptin. Now, this is another study which showed that about the weight. So effective sitagliptin compared to sulfonylurea control and metformin, the two arms, a base of metformin, one with sitagliptin, one with sulfonylureas. With sitagliptin, more or less, it will be slight weight reduction, weight neutrality compared to sulfonylurea, which can increase weight by up to 2 kgs. And also, treatment with sitagliptin produced similar change in fasting plasma glucose from baseline. There was a short 4.5-month RCT, which showed a more significant reduction in fasting plasma glucose with sulfonylurea. As you know, sulfonylureas are full drugs. They reduce the A1C, control the fasting plasma sugars, and subsequently the postprandial sugars very well, And therefore, we still use them when the A1C is very high to present, and then readjust the dose as the A1C falls. So very good to start. So compared to this sulfonylureas, the effectiveness is very, very similar for sitagliptin in type 2 diabetic patients. So comparing the A1C, more or less very similar A1C reduction as far as the A1C is concerned. And there was another long study, 36-month cohort study. It explored the risk of needing treatment change. That is, you're on a treatment, and how long does it work before we add on a drug to reduce the sugars further? So they found that the risk of needing treatment change was low with sitagliptin. That is, long-term compliance, long-term durability of sitagliptin is more than sulfonylureas. In another study, 72-month cohort study, demonstrated that individuals prescribed sitagliptin had a low risk of initiating insulin during follow-up after relevant adjustment. So that's also, all these are very significant. Durability is more. People taking sitagliptin needed a lower risk of initiating insulin at a particular time. So coming to dapagliflozin, its intermediate efficacy, again 0.5 to maybe maximum 0.8 reduction in A1C. It's the insulin-independent action that is very, very important. It has multiple pleiotropic benefits, both cardioprotective and renoprotective, and now it has become quite affordable to use in most of the patients who require this drug. Now, how does SGLT2 inhibitors, how do they work? What is the mechanism? We know it's on the renal side, the kidney. It reduces the glucose-sodium reabsorption, and therefore there is increase in the glucosuria. And there's also increased sodium to distal tubule, and it reduces intraglomerular pressure and increases the glucose excretion. Therefore, the outcomes on the kidney part is sustained eGFR decline, reduction in ESKD, progression to ESKD, reduction in CV death, and reduction in hospitalization heart failure in all patients with CKD. And plasma glucose also comes down in these patients. So coming to the other factors in circulation, there's vascular factors, there's reduction in plasma volume, and therefore systolic blood pressure comes down. On the heart, it reduces the preload and afterload. So because of these multiple factors on the vascular system, hospitalization of heart failure came down when use of dapagliflozin, multiple risk factors, or ECVD and inpatient hospitalization with reduction of EF. So all these are major benefits when we use dapagliflozin in our patients. And once that happens, when the heart failure is we're able to control, the CV death also comes down. And also, coming to neurohormonal side effects, this downregulation of elevated sympathetic activity, which lowers the sympathetic drive on the cardiac rate and therefore can reduce the arrhythmias also. We know how dapagliflozin works, is SGLT inhibitor, so I don't think I need to tell you more on this. Now, landmark trials of dapagliflozin include declared kidney trial, the CVOT specified CVOT trial in 2019, DAPA-HF trial with reduced ejection fraction in 2020, and also the CKD trial, DAPA-CKD in 21, and DELIVER trial, where indication expands all heart failure patients with or without diabetes. So we have ample evidence, number of patients were more, and we have adequate evidence to show that dapagliflozin monotherapy in drug-naive patients with diabetes. So compared to placebo in this trial, 1 milligram, 2.5, and 5 will be used, and you can see the HbA1c difference from baseline. When we use a standard drug 5 or even 10 mg, the reduction of 0.82 can be expected on a base of A1C levels. So this was a good trial as a monotherapy in patients, right? Okay. And dapagliflozin monotherapy in people who are inadequately controlled, no glycemic control in these patients at the end of 24 weeks, compared to placebo, dapagliflozin 510, we can see a significant reduction, 0.89 with dapagliflozin, or 7 reduction in A1C levels. So this is a good we have when we use 5 to 10 milligrams of dapagliflozin. Now, if you look at the A1C monotherapy or add-on to metformin or SU or a combination with metformin or with insulin plus OADs, there's consistent reduction in the A1C up to 0.89, maximum 0.96. So consistent reduction in the A1C is seen across monotherapy or add-on to other drugs which we use to control. And there's another study also which showed on a high base A1C, about 9.4, we can reduce the A1C by 1.9, and also additional benefits when we add to metformin inhibitor, or so it can be clubbed with most of the other OADs or insulin to get consistent results. So what is the rationale for combining these two specific drugs, a DIPO inhibitor on one side, as well as inhibitors on the other? One, we know both have a safe, rapid, and sustained glycemic control. Durability is long. And they have a complementary mode of action. They target multiple pathophysiological abnormalities, which are found to be in tau type 2 diabetics. They reduce insulin resistance and improve beta cell function. Also has pleiotropic effects like reduction in body weight and blood pressure, and reduces the number of pills that the patient takes. Therefore, the adherence and long-term compliance improves for these patients. Now, what are the complementary modes and how these two drugs work? We know the SGLT inhibitors work on the kidneys, and therefore they reduce the weight, BP, glucotoxicity is reduced. This DIPO inhibitors work on the pancreas. Increase the beta cell sensitivity, increase glucagon, and dual pancreatic effects are there. So this comes in from the intestine where the GLP-1 and GIP increase because of inhibition of DPP4 enzyme. And therefore, we reduce not only hyperglycemia, but also provide pleiotropic effects of SGLT inhibition. And these are complementary mechanisms of action that pathways, multiple pathophysiological changes that cause hyperglycemia. Now, this another trial, defined in an Indian diabetes setting, where appropriate use of SGLT2 defined because FDC based on glycemic factors. So what happens is we initiate a lifestyle modification first. If you look at the treatment naive patients where metformin is contrasted is above 8, we can use this combination. Or in people taking metformin, but where baseline A1C is more than 9, not controlled with metformin monotherapy, we can use this combination. For people who are uncontrolled on metformin monotherapy, we can add this combination. The A1C is high, say about 8.5%. So these are the indications for using this combination in various settings in our diabetic population. Now, appropriate use of this drug based on glycemic control. So people taking metformin and uncontrolled, do we add it as a second line? Yes, we can add this as a second line therapy, either if inhibitors, SGLT inhibitors, along with the background of metformin, or use on other drugs when the A1C is not under control. And insulin other agents may be needed subsequently if the glycemic levels are not under control. Of course, this is based on individual approach. So we need to ensure appropriate titration of insulin to get these people under control. So beyond 3 drugs, probably we need to add insulin instead of loading the patient with other OADs. Now, the criteria applicable as above we saw, SGLT inhibitors have proven CV and heart failure benefits. So cardiovascular disease, including heart failure, the number of events can be reduced in these patients. DIPO inhibitors with proven CV or HF safety, like linagliptin, sitagliptin, have a favorable CV safety. They have a good CVOT trials, and we know that they are pretty neutral as far as CV events or heart failure is concerned. So this combination may be preferred for other conventional therapies that have no proven CV benefits in case of established CV disease or heart failure risk is present. Now, H1A1C criteria is above. SGLT, even though it is mentioned as EGFR greater than 45, I think trials have shown we can use it even with EGFR is about 20. The recent trials are there. Of course, the safety is initiation versus continuation that we need to differentiate when the EGFR drops down. We have a lot of proof showing that positive kidney outcomes in CVOTs, and therefore we need to use drugs like SGLT inhibitors and to prevent kidney progression, kidney disease progression, or to reduce microalbuminuria. So this combination may be preferred over other conventional glucose-lowering therapies. Now, HbA1c criteria applicable is above. SGLT inhibitors promote weight loss. They are DIPO inhibitors are weight neutral, and therefore this combination again may be preferred to other conventional therapies earlier to promote weight loss with no significant increased risk of hypoglycemia in type 2 diabetes management. So this combination, as we saw in the Indian diabetes setting, has multiple major benefits, and we can use this as a drug in various settings. This is another trial with a 24-week extension period where, as an add-on therapy to sitagliptin with or without metformin. This is a 24-week multicenter randomized double-blind placebo-controlled trial. As you can see from this graph, this is sitagliptin trial. HbA1c adjusted from baseline, and if you add a dapagliflozin, the significant reduction in the HbA1c from the baseline. Likewise, the percentage change adjusted from change from baseline here with sitagliptin plus sita-DAPA, there's a significant reduction. Therefore, this dual combination or in triple combination with sitagliptin plus metformin was well tolerated in this study at the end of 24 weeks. Led to clinically meaningful reductions in glycemic parameters and body weight and sustained throughout the 48 weeks of treatment. So sustained benefits are accrued with this combination. Now, dapagliflozin provides additional clinical benefits in type 2 diabetic patients who are inadequately controlled with sitagliptin plus or minus metformin. This is again another study. This is the combination sita plus DAPA shows significant reduction in the A1C compared to sita-metformin. So this trial had 10 milligram dapagliflozin in dual combination sitagliptin or in triple combination with metformin. It was well tolerated, clinically meaningful reductions in glycemic parameters and body weight throughout 48 weeks of treatment. The SIDAXA study was a retrospective observational study. It assessed sitagliptin dapagliflozin, a fixed dose combination in Indian population with type 2 diabetes. 328 people, real-world retrospective observation study in 111 Indian centers. They assessed the management at baseline, week 4, week 12. They checked the A1C, fasting and postprandial plasma glucose levels, the LDL-C, systolic blood pressure, diastolic blood pressure, and if there were any change in the body weight. So if you look at the results, this fixed dose combination reduced the baseline A1C from 8.36 to 7.31 at the end of 12 weeks. And these are the mean values, baseline, week 4, week 12. And this is the fasting plasma levels, these are postprandial levels, again showed a significant reduction from 242 to 170, fasting levels 165 to 123. So this combination improved glycemic control and lipid profiles in type 2 diabetic patients, particularly in those with a background CAD. Favorable safety profile, so its potential is an effective and well-tolerated therapeutic options in patients who have an established cardiovascular disease. This results from the SIDAXA study. From a cardiologist perspective, how does this combination really work? Dapagliflozin, sitagliptin. There's 98 cardiologists from across India, patients type 2 diabetic, high risks for CV complications. They were advised to explore the challenges and strategies for treating these kinds of patients with a background cardiovascular disease, and whether DAPA and sitagliptin were used. The primary outcomes were whether the FDC of this combination, FDC DAPA and sitagliptin, reducing the CVD risk in patients with type 2 diabetes. Results showed that the choice of glucose-lowering drugs among these experts was this combination, SGLT inhibitor, DPO inhibition, compared to metformin or as other monotherapies. It provides valuable insights from leading cardiologists that would support clinicians in selecting the synergistic combination of a DAPA sitagliptin FDC is the appropriate treatment choice in early intensive therapy in managing diabetes and CVD risk for better patient outcomes. And therefore, there's a choice of all cardiologists to use this drug. So coming to triple combination of sitagliptin, DAPA, or metformin. Now, these three drugs, and look at the ominous octet. These are the various pathophysiological changes from the pancreas to the liver, to the brain, the muscle, the kidneys, and the fat cells, the adipose tissue. So all these are important as a background changes that cause hyperglycemia. So if you look at this common DPO inhibitors, as I mentioned in the previous slide, major effect on the beta cells of the pancreas. And they also work on the intestine, as though the DPO inhibitors work on the GLP system. And SGLT inhibitors work on the kidney. They decrease the glucose, increase the glucose reabsorption, and therefore reduce the glycemic parameters. And at the muscle, DPO inhibitors, H inhibitors, metformin, they increase the insulin sensitivity, therefore increased uptake is present at the muscle level. And at the liver, increased SDP with this combination and metformin DPO inhibitors. So all these drugs, as you can see, seem to at least have a major say on how the ominous octet can be controlled with this combination of three drugs. So this is how we address all the pathophysiological changes with this triple combination. So you address at the pancreatic level, you address at the liver, at the brain neurotransmitter dysfunction and the reduction in satiety, muscle increased peripheral resistance can be decreased at the kidneys and at the adipose tissue. We know that adipose tissue, especially when there is increased lipotoxicity due to increased what's called hyperglycemia, is a major reason why people go into complications. And we know fat cells are the adipose tissue, the extra pancreatic fat, the extra hepatic fat, the fatty liver, then the fatty kidney. All these can cause major problems with the cytokines and cause increased inflammation, and therefore not only increase atherosclerosis, but also reduces the endothelial dysfunction, can increase apoptosis, can reduce the podocyte function and basement membrane inadequacy. So various ways how the SGLT inhibitors work. Now, these are the major side effects. Now, having known the benefits of these two drugs, we also know how these drugs can be the major side effects that can be caused by using dapagliflozin. One earlier, yes, the DKA risk or euglycemic DKA that we need to keep in mind. So if it is suspected, we need to discuss, evaluate, treat promptly the background reason. And this is one thing we need to keep in mind. And also, before scheduled surgeries, we need to stop between at least 3 to 4 days. Any critical illness, patients who are admitted in the hospital, they all need to stop this drug. The risk of genital myocardial infections is higher with these drugs. Also, reported case of necrotizing fasciitis of the perineum, the Fournier's gangrene, institute prompt treatment if suspected, and also attention to volume status of the patient, blood pressure we need to monitor, or just other volume contracting agents applicable. So we need to be aware of the potential side effects of using SGLT2 inhibitors. So that is extremely important. And this will tell you whether the patient is suitable for this trial, or we should also know when to stop using these drugs and warn the patients, counsel the patients to stop these drugs if suspected illness is present. Coming to DIP4 inhibitors, what are the side effects that can occur? One is the pancreatitis, reported cases, but we should be aware, even though the incidence of pancreatitis is much lower, we need to be aware that the increase in pancreatic enzymes can be caused by DIP4 inhibitors. When you suspect pancreatitis, the enzymes are very high, or symptomatically pancreatitis is suspected, we need to discontinue these drugs. Joint pains, we know that both ankle and increased what are called the inflammation in the joints can occur with these drugs. So when you suspect it, again, stop it. Now, the potential problems which we do see nowadays is a bullous pemphigoid, discontinue again if suspected. So these are the main things we need to be aware when we use SGLT inhibitors or DIP4 inhibitors. So this is extremely important. Now, benefits of this combination, triple combination, one is effective glycemic management. The A1C is more than 1.5 above the target goal, we can use this. Heart failure patients, patients with CKD, patients who have compliance problem, we can use once pill a day. It's become cost effective and it's weight neutral. Now, durability of this combination. Now, let's see what happens. With triple therapy with these agents, improve insulin sensitivity and beta cell function in new onset type 2 diabetic patients. And therefore, if you can look at the triple therapy combination versus the conventional therapy, fasting plasma glucose 191 to 128 in the 3 years, 2-hour postprandial sugars 320 to 156, A1C 9 to 6.4, and also the all indices, which and the especially Matsuda index shows that there is increasing insulin sensitivity in this patient who is triple combination. Conventional therapy we used to have earlier, of course, it came down at 3 years, but not so good with especially as far as the insulin sensitivity is concerned. The Matsuda index, as you can see, in fact, came down from 4.1 to 3.4, compared to 2.9, increased to 9.3. Therefore, triple agents definitely have a better connect as far as the A1C reduction is concerned. They also improve insulin sensitivity, and that's very important. Beta cell function also can improve in new onset diabetic patients. The durability is long. A1C reduction is also prolonged than conventional agents. And also you get a risk of hypoglycemia? No. All these agents do not have major risk of hypoglycemia in this EDIC study. But there's another triple FDC trial where DAPA with SITA with metformin in patients with type 2 diabetes poorly controlled on metformin in the phase 3 study. which showed that the triple drug, FDC, the event reduction was 1.73 at the end of 16 weeks compared to using Sita plus Met or FDC of DAPA plus Met. So using dual combination produced an events reduction of roughly 1.3 compared to 1.7 with triple combination. Therefore, when we use this as a single drug, we seem to get better A1C control, better glycemic control versus dual combination therapy. This is another multi-center trial to evaluate the safety and efficacy of DAPA plus sitagliptin plus metformin versus sitagliptin metformin in type 2 diabetes who are inadequately controlled with the two-drug regime. So with the two arms here, the randomized to 1:1, one arm getting FD's DAPA plus Sita plus metformin versus metformin plus DAPA or sitagliptin. Therefore, these patients had a dual therapy or a triple therapy. The results showed that arm X triple therapy produced an A1C in a 1.72 reduction compared to 1.07, and also change in faster plastic glucose and the postprandial glucose levels. If among patients with type 2 diabetes or poor glycemic control with metformin monotherapy, triple drugs achieved a better glycemic response compared to dual FDC, but with similar comparative safety profile and tolerability profile in these patients. So to summarize, estimated number of Indians having diabetes is increasing rapidly. So up to 130 million by the end of 2045. There are limitations to conventional anti-diabetic drugs. We know there are issues of severe hypoglycemia, there can be weight gain, the efficacy is lower, improper ineffective dosage regimen, etc. So these three drugs, SGLT inhibitors, GLP-1 receptor agonists, D4 inhibitors, are commonly used due to their good efficacy and good pleiotropic benefits. And combining these drugs, we address multiple pathophysiological mechanisms leading to robust glycemic control and addressing the unmet needs in type 2 diabetic patients. Sitagliptin is a time-trusted D4 inhibitors with over 2 decades of clinical experience. It lowers the A1C with once daily dosing, and dapagliflozin allows for better glycemic control and potential weight loss in patients who are diabetic. It also offers additional benefits apart from the A1C reduction, and combination of both offers rapid and sustained glycemic control. Triple therapy is effective. It's better than dual therapy in achieving a better A1C reduction, as we saw in the last trial. And combination therapy with DAPA, sitagliptin, metformin, it's a promising therapeutic option in management of patients who are poorly controlled. And we have evidence to show that triple therapy is better than in achieving glycemic control without any significant safety concerns. Of course, we need to address the safety factors, which we already mentioned, the side effects we need to keep in mind when we use both DAPA or any other inhibitors and D4 inhibitors like sitagliptin. Thank you so much for your patient hearing.
Thank you, Dr. Vamsi. You have very well highlighted about all the three molecules and the Sita plus DAPA, Sita, DAPA, and metformin. Of course, we too had a triple drug combination in the form of metformin, sulfonylurea, alpha-glucosidase inhibitors, metformin, sulfonylurea, pioglitazone. Those triple drug combination also in India very vehemently promoted just 15-20 years before. Of course, when compared to those triple drug combination, this triple drug combination is so many times superior. They address the core pathophysiology, maintaining the good control without causing hypoglycemia. If you start the patient on metformin, sulfonylurea, pioglitazone or metformin, sulfonylurea, alpha-glucosidase inhibitors, if you start 100 patients this month, definitely 20 to 30% during next review, they will face hypoglycemic symptoms. But here they will not face hypoglycemic symptoms. That is the major advantage. Of course, there are few drawbacks which can be addressed in day-to-day clinical practice. So he has very well covered. We can go for question and answer session, Dr. Rishikesh.
Yes, sir. There are some questions in the chat box.
Chat
If you
box,
are
yeah,
able
I have
to,
seen.
yeah.
So what is the patient profile for Sita-DAPA combination? Of course, Dr. Vamsi has addressed it. Again, he can highlight.
I think one is the repetition.
Yeah.
We have changed the way we treat patients. No more it is a monotherapy. No more it is escalation of monotherapy before going to the second drug. We know if A1C is 7.5 or 1.5 above the target, we can safely use this combination with DFO inhibitor and SGLT inhibitors. So patient profile would be one, a patient presenting with, say, a higher A1C at the diagnosis, or patients on uncontrolled initial monotherapy, and straight away we can go into this combination therapy. So most of the patients would fit into this combination, especially Indian patients who have high inflammatory state because of the adipose tissue we have in the visceral adipose tissue. We know visceral adipose tissue is a major inflammatory factor, and therefore, when we need to address the reduction in fat, it will be the best drug is to use the SGLT inhibitors. So I think it will fit in most of the Indian phenotype patients who have the risk of early cardiovascular disease, early CKD compared to Western population. I think this will be the patient profile. So
of course,
I think
one
that
more
the
to
way
add, Vamsi. Suppose the patient is in catabolic state. So if you add DAPA,
no, not
such
that. That's
catabolic
why.
state,
Yeah, that's true. What you say is true.
yeah,
The patient has lost
lean
due to
people,
hyperglycemia. This may not be
yeah.
the choice at that time.
So that patient profile also you have to keep it in your
Yeah.
mind. It may reduce the blood
If you
sugar.
keep any symptom of glucotoxicity, this is not the combination to use.
Yeah. So in catabolic state or
that we
there
need
is
to
gross symptomatic, polyuria, polyphagia, polydipsia, and gross hyperglycemia. This drug may reduce the blood sugar, but the patient may feel extremely
No.
tired and weak. Sometimes they
Right.
enter into euglycemic decay also.
DK
Those category better avoid. So these are all the patient profile.
That's
But we
correct.
have to
So
use
symptomatic,
carefully.
yes, symptomatic hyperglycemia, patient already thin, or we have sarcopenia may not be a good drug. Yes.
The second question, do you use Sita plus DAPA metformin combination in treatment drug-naive patient?
Treatment naive patient. Second, it
Treatment.
depends on what time we see the patients. The patients come with, say, an A1C between 8.5 to 9. They have no symptoms of hyperglycemia, no weight loss, no catabolic state, nothing. And probably we can use this drug within keeping in mind, and that will be the patient profile to select this drug. So probably we need to choose the patients, right patients to use this combination. So I think we have had evidence, I think, with this triple combination in patients who have not been getting treated. So the A1C above 8.5 probably may be a choice of drugs for these patients.
Sometimes triple drug, yes, if you are having clinical experience, obese patient, as he told, asymptomatic, you can start. But again, we do not know which patient will respond quickly, which patient will not respond quickly. Sometimes triple drug may cause low sugar symptoms. They will not enter into hypoglycemia like sulfonylurea therapy. They feel extremely tired and weak sometimes because of at a time giving triple drug, that too initially.
Yes.
So no harm in initiating with the 2 drugs with the lifestyle modification. Then after 3 months of follow-up, then you can add or you can go for triple drug combination. That way also you can. Being a drug-naive patient, already he may be diabetic asymptomatically for so many years. So let us not go fast. So let us give 2 drug combination, metformin plus DPP-4 inhibitor.
Yeah.
Huh?
Another problem is with the full FDC is titrating the dose. It's very difficult to titrate the dose.
Titrate. So that only you wait for minimum 3 months next A1C. Responding well for double drug, continue.
Yes.
So there is no adequate response, then go for single pill, triple drug therapy. Right. What are the advantages of Sita and DAPA based combination over DPP-4 and see, nothing, see, here you are generic and there is DPP-4 and SGL. You can tell.
Yeah.
I
think with all the evidence we have had, we saw that ADA guidelines 2015 to 2025, remarkable change. So I think when we look at this older combination, glimepiride, bioglazine, metformin, versus today's combination, definitely, if you look at the patient profile, initial way at the time, assessment must be done. Whether they have a background cardiovascular risk, obesity, family history of cardiovascular disease, or there's any myocardinuria or LVH. In all these patients, probably it's a good way to start the drug. If there are no cardiovascular in the sense, no risk factors, Then do we go to conventional treatment? Do we do that? It's again, we need to identify which patients would benefit for what. So I think we cannot right away, we cannot discard pioglitazone or metformin combination. Pioglitazone is still very useful to reduce or increase the insulin sensitivity. It's also recommended in patients who have a fatty liver disease. Therefore, we need to keep the patient profile in mind and then choose the drugs appropriately. So that is very, very important. So the AD guidelines say, yes, we can use a SGLT inhibitor straight away when there is suspected background cardiorenal risk is there. Definitely we can do that. In the current era, where multiple DP4.
Go ahead.
Yeah, this question is there. In the current era, where multiple drugs, DP4 inhibitors, SGLT inhibitor combinations are available, which one do you prefer and what are the criteria for selection of any particular DP4 inhibitor and with SGLT2 combination? I think basically both DP4 inhibitors and SGLT inhibitors have major class effects.
Yes.
So choosing the drug, this or that, may not, as far as the A1C is concerned, most of them are very, very similar.
Yeah.
They have similar weight reduction, similar reduction in the systolic and blood pressure. And also, most of them have classic benefits on heart failure. Even though we have had trials showing empagliflozin is better as far as the CV death or cardiovascular death is concerned, that again depends on the trial, how the patients have been selected. If all the patients have cardiovascular disease, definitely the reduction will also be better. To reduce heart failure, definitely the events as far as CV death are concerned would be coming down. So I think basically, I think most of them, these combinations of either DP4 inhibitor or SGLT inhibitors are common. The only thing we need to keep in mind is at what EGFR the drugs need to be reduced. Especially sitagliptin, we need to reduce the dosage to 50 or even 25. So likewise, that we need to keep in mind with the EGFR. So where these drugs fit in. Do we initiate SGLT inhibitors at very low EGFR? That's also debatable. It can be continued where the patients are already on SGLT inhibitors and probably stop it during dialysis. But again, there are no trials in patients with dialysis also going on. Probably will expect results a little later. So I think this is again individual selection. There's no particular way to say this combination is better than the other combination. Dr. Paneer?
Yeah, see, what this question is the current era where the multiple DPP4 and SGLT inhibitor combination are available. Which one do you prefer? Which you have clarified already. See, all class effect only, both DPP4 as well as SGLT inhibitor class effect, except some subtle difference. For example, SITA and LINA will act for 24 hours. VILDA will act for only 12 to 18 hours. So there are some, and inhibition also. There are some few percentage, few will inhibit more than 80, few will inhibit around. But clinically, we don't come across any difference. Clinically, all are same, all are having the same class effect, whether it is a GLD inhibitor or DP4 inhibitor. So we are moving to the last question. Beyond glycemic control, have you observed benefits in weight reduction, blood pressure modulation, and NAFLD markers with the SITA and DAPA-based combination therapy in your practice?
Yes, I think so. Definitely, we see weight reduction. In fact, some patients have such a weight reduction, we need to stop the drug. It happens in a select patients.
10 kg. Some of the obese people are reducing 10 kg, which we are not come
and
across.
they seem to have lost so much weight and also muscle. The problem is, even though these drugs seem to reduce the fat, but they also, in the sarcopenic patients, this is the problem in these patients. So we need to have not only reduction, but also make them do strength training, good physical activity to retain the muscle strength. That's very, very important. The slight reduction in blood pressure, yes, all of us know that. And also it's recommended in now MASH and all that. So when you have elevated liver enzymes corresponding to NAFLD or the new term or MASH, of course, these drugs are the choice now, right?
So to add on that, after the arrival of which I have told you at the initial conversation or initial of the meeting, so after adding SITA plus or minus DAPA with the metformin sulfonylurea combination, we are in a better position to remove sulfonylurea for almost 20 to 30% of the patients. So even in your practice, this is all over nation going on. If you're in your practice, you come across like that, kindly downwardly titrate the dose of sulfonylurea. If the patient is on
Yes.
either BD or OD, after adding your reduce the sulfonylurea combination. Patients sometimes they themselves stop because this molecule was not causing hypoglycemia. After adding these two only, I am frequently facing hypoglycemia. Of course, as a patient aspect, they may suspect this drug. But as a clinician, we should reduce the sulfonylurea dose to 1 milligram, then subsequently 0.5 milligram. Subsequently, we can stop sulfonylurea for many years, and they both are beautifully controlling diabetes. Otherwise, beta cell function is restored. Beta cell function is brought back by so many ways. So many ways in the sense, your dapagliflozin eliminate the excess glucose in the urine, and your sitagliptin persistently by elevating the GLP-1 restore the beta cell function. Whenever the blood sugar goes high, it stimulates the beta cell, suppresses alpha cell. Whenever the blood sugar comes down, it suppresses the beta cell, stimulates the alpha cells. Otherwise, the islet cells are put into physiological action by this molecule. So metformin, in addition to clearing the insulin resistance at the hepatic level, it also promotes some amount of GLP-1 synthesis. This chronically elevated GLP-1 restores the beta cell function. We are in a better position to remove sulfonylurea and insulin also, the so-called insulin requiring type 2 diabetes. 20 years, 25 years before, we were under the impression they lost all beta cell function after 15 to 20 years of diagnosis of diabetes. They behave like type 1 diabetes. That was the impression we had up to the year 2000. But after introduction of the GF molecule, those patients who have been labeled as insulin requiring type 2 diabetes are coming away from insulin. So to that level, this molecule is helping. Especially after the arrival of SGLT inhibitor, we are reducing the antihypertensive dose, few percentage, about 5 to 10% of the people, even we stop the antihypertensive. But we have to monitor. That is more important. At any time, again, this may go high, this may go high.
Yes,
we have to
right.
monitor. But these are all the clinical observation, which we have not come across before the year 2000. Before the year 2000, achieving A1C 7 also very difficult. Now, achieving A1C less than 6.5, even in the age of 70 or 80, without hypoglycemia, it is very much possible after the arrival of SGLT inhibitor as well as DPP4 inhibitor, along with our so-called metformin for more than 65 years in India, plus or minus your AGI. So otherwise, beyond glycemic control, these molecules are, so sulfonylurea controls blood sugar only, insulin controls blood sugar only. But these two molecules, as they have mentioned, beyond glycemic control, these are all the positive benefit. Weight reduction, blood pressure reduction, beta cell restoration, glycemic your variability is getting nullified, no hypoglycemia, smooth control of diabetes. So these are all the beyond glycemic control advantages. But on top of it, lifestyle modification. So lifestyle modification, they have to diet and exercise, they have to follow. And we clinicians should closely monitor. You should encourage all your patient to go for self-monitoring. With the self-monitoring report, you have to review the patient. Such interest we also should show. So the current treatment for the past 15, 20 years is definitely helping our patients. So such meetings are helping us to translate this benefit or to share the knowledge nationally and give better benefit for our patients.
Yes, absolutely.
Thank you, sir. Thank you for
So
summing up the
I think
discussion well. And I think concluding remarks cannot be better than this, sir. Thank you, sir. So before we conclude, we are nearly at the finish line. But before we conclude, let's express our gratitude to all those who made this program possible. I would like to express my sincere gratitude to our esteemed moderator, Dr. A. Panir Selvam, sir, for sharing his research, knowledge, and expertise with us today. I extend my deepest gratitude to our distinguished speaker, Dr. Vamsi Mohan sir, for his insightful presentation. Your deliberation has undoubtedly expanded our understanding pertaining to role of CETA and DAPA-based dual and triple combination therapy. I would also like to thank our esteemed audience for their active engagement and for making this program a resounding success. On behalf of Emcure, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at Emcure who have contributed to this program success. Let's carry this knowledge into our practices, research, advocacy, and fostering a healthier future for patients suffering from diabetes. Thank you once again for attending and encouraging us. Have a great time ahead. Thank you.
Thank you, Rishikesh. Thank you,
Thank you,
Vamsi.
sir.
We'll meet in
Thank you, Dr.
physically
Punya.
somewhere. Thank you.
Thank you, sir.
Shivani.
Thanks a lot. Thank you.
Thank you. Thanks to all delegates participated.
Thank you.
Thank you.
Recording stopped.